I'm going to talk a bit today about our perspective from the federal government, from a public health agency, where our goal is to bring science to practice all the way down to the communities and to not only assess what climate change will do to health, but to put things in action that will actually protect people. I'm going to talk a bit about BRACE, but I'm going to talk a bit about all of our activities that lead up to this evidence-based approach, which is what we heavily rely on when we develop policies and programs. And you guys are familiar with these two reports. Increasingly, these are impactful when these get done. Yeah, especially this one right here was, and Jonathan was the coordinating lead author, or convening lead author, whatever it is, for the first assessment. And it was more like an academic paper. And it was thorough. It had all the proper references. And I was the CLA for the last one. And we wrote it, and Susan Hassel, a communications person, said, no, just start all over. And we wrote the thing already. And she said, this has to be a communications piece. And you have to think about not just the details about what the facts are and the data that have been accumulating, but to spin a narrative and develop this kind of causal pathway that will then communicate this idea better, because we're not doing a good job of it. The opposite is the IPCC reports, which are deadly weapons if you try to carry them around. They're so massive. And they don't convey this communication message very well. But what we have summarized in the NCA report is that we're dealing with two phenomena related to climate change. Actually, there's a third, which is carbon pollution independent of weather, but I'm not talking about that today. You guys, this is for another meeting, I guess. But we're dealing with two phenomena: changes in the mean temperature for a location and changes in the variance, and also a great amount of heterogeneity with the way these impacts play out. And from a federal perspective, that's extremely important. From a public health perspective, the fact that we have shifting curves, and not only the curve moving to the right, but the curve flattening, is very important for public health, because these are our natural disasters. These are the things that we have built resilience to, built coping capacity, and now we've blown right past that coping capacity. And we need to understand how to expand that coping range, how to build systems that are more attuned to the weather of the 21st century, because the variance has shifted so much, and normal weather is not normal anymore. We also understand that as we develop a national program, I mean, people ask me, what's going to be the National Adaptation Plan for Health? I said, there'll never be one, as long as I have something to say about it. Because you can't develop a one-size-fits-all plan that addresses all of this difference in change. We have Minnesota with over 3 degrees, and Colorado over 3 degrees of warming. If you live in Alabama, there is no global warming. It's cooled. And Georgia, we're pretty ambivalent about it too. Now, I think a lot of this has to do with reforestation of the South. This is when you take your time period. But it's important for all of these places, and Alabama especially with is being impacted. So back to the National Climate Assessment. We actually finished this one just in 2014, and we're already starting the next one last Friday. An important statement that came out of this was, for the first time, we say some of these impacts are already underway in the U.S. This isn't, and we're reframing, this is a communication challenge that Jay mentioned, from impacts distant in time and distant in place to here in our communities and now. And it's a threat amplifier. It's amplifying certain threats, and certain communities are especially vulnerable. And we know who those are because they intersect across a lot of exposures. But as Jonathan mentioned in his comment, there are things that we can do that have benefits for health and climate change, and we should seize upon those. So there is a positive prevention message. In addition to outlining some of the health endpoints that we'll be dealing with, CKD, heat waves, waterborne disease, et cetera, it's important to identify what the causal pathways will be. What are the key ways in which health will be compromised, not what are the key health threats, the endpoints. So there are 3 that I'm going to talk about today. And the first is that climate change, by altering and degrading a lot of basic environmental conditions like water quality, air quality, et cetera, is going to add to the cumulative stress currently faced by vulnerable populations. A gradual increase in ozone exposure, particulate matter from wildfire, poor water quality from heavy precipitation events. These aren't events in the classic sense of a disaster. They don't make the news. The increase of 7% in asthma prevalence isn't going to be something that grabs people's attention. But if we look in various places, CKD, as you guys are expert on, that we see this cumulative degradation, and these impacts do have cumulative impacts. You know, heat stress and air quality work together. So these are going to be an ongoing, persistent, not event-based type phenomenon. And they can be quite serious. This is Kim Knowlton's work and Perry Sheffield, looking at just in the next five years from now, projected changes in asthma pediatric ED visits, upwards of 10% in some of the downwind communities, all as a result of increased warm days, affecting ozone production in urban areas. And we'll see this across the country dramatically with pediatric cases. We'll see increases in ragweed. We, at our program, have a lot of work in pollen and health, and we've shown in Atlanta, for example, the last 14 years, a very sharp increase in every species, like 16 species, except for maple for some reason. We can't figure that one out. But we're seeing it not only as it's affected by temperature, longer growing seasons, these can produce pollen longer, but the CO2 enrichment of these plants that is increasing. This is Lou Ziska's study where he showed that in urban areas, this is rural Baltimore, he took a ragweed plant, a clone, three separate clones of the same plant, the same soil, and the same conditions with inputs of nutrients and water, and grew them in 3 plots across a latitudinal transept across Baltimore, and showed that the urban species, just as a function of increased local ambient CO2, this is, urban cities have a lot more, urban areas, 500 parts per million, that it produced over 12,000 grains per cubic meter of air versus kind of background at 22 and 32. So there's an effect going on here, and we see it in Atlanta. We're now collecting data for many parts of the country, developing a national pollen network, working with the Council of State and Territorial Epidemiologists. And this doesn't get noticed a lot. Oh, I got bad allergies. Well, we spend over $15 billion a year in treatment costs for allergic rhinitis. And lost productivity days are incredibly important. So, yeah, it is a big deal. The second key health threat is that we get natural disasters and we get extreme weather events. That's the baseline. But the increased frequency and magnitude of these events threatens to overwhelm our coping capacity and put into play some of those most vulnerable systems that we rely on, energy, transportation, communication, that then help safeguard lives. So the way climate change acts on natural disasters is to amplify their return period and frequency, and magnitude, such in a way that it has overwhelmed what we've put in place to protect people. We saw this in Paris 2003. Jay was telling me this morning, he's like, man, I got some of your slides. I shared them a while back, and what I didn't tell him is that I got them from Jonathan. But it's all derivative. But what we see here, and I was actually an EIS officer in France during this heat wave and had worked with him for a year on the analysis. This wasn't like a bad meteorologic event. It was. But it was a massive system failure. There were so many things that went wrong that shouldn't have gone wrong. They never recalled their physicians from their August vacation. The nursing homes were, everybody was out of town. And when you go out of town, if you have an elderly relative that can't travel, you put them in the nursing home for the month. Not kidding. And those nursing homes were full to the brim. They didn't have air conditioning. They didn't think that they needed air conditioning. Even when we went there, the day after the heat wave, we met with the minister and he said, what should we have done? I said, we use air conditioning when it gets hot. He was like, well, isn't that bad for you? Are you worried about Legionella? I said, are you worried about 70,000 dead? No, that was exactly what they said. It was a massive mindset of not being aware that this was a health threat. And numerous problems after problems. One thing that they got lucky about was they didn't lose power. And we see that power outages, which are much more likely during heat waves, especially prolonged heat waves, not just because of excess demand, but the challenges on transmission of electricity. This is not a heat wave. This is just losing power in New York City. And you see what happens in accidental and non-accidental deaths. In France, in 2003, they came within a fraction of a degree of having to shut off their nuclear power plants because the cooling ponds were too hot. So that would have been great. We see, Katrina J showed this, and this is, when we think of disasters, we can't think of it merely as a place-based phenomenon. These radiate out, these impacts. We worked with the city of Austin, Texas years ago on a hazard vulnerability assessment. And after they went through all the meteorologic data and hazard data, they said, what is the principal thing you want to work on? They say, hurricanes. When was the last time you had a hurricane? So we've never had a hurricane here. But every time there's a hurricane, we get 10,000 people showing up with needs. And we have to deliver for them. We have to prepare for that. We have to give them services and food and WIC and everything. The third key health threat that we're modeling is surprises. And these are large-scale ecological perturbations, and we will have massive changes in where things are going to crop up. We can do things like modeling. This is John Brownstein's modeling showing where Lyme suitability would be moving into 2080. And this gives us, a tool to look forward to the future. Modeling is important. This is the actual CDC data of showing what John was predicting. That's 2011. So it is following that path. So there is some validity to doing these types of prospective or anticipatory public health work like I talk about. But we're not just dealing with a few health threats. We're really dealing with a variety of parameters from temperatures, weather extreme, sea levels, and CO2, which we haven't talked about, are going to impact a wide variety of exposures, not just the ones I spoke about, which in turn will in fact impact a wide variety of health outcomes. This is a lot of stuff to deal with. So when we talk about adaptation, we have to cover a lot of territory and focus on building the capacity, building the human capital in order to address these many, many concerns, which just a few won't do. So this is what we do at CDC. We help cities and states, we're a domestic adaptation program, prepare for the threats of climate change by doing, providing scientific guidance, decision support tools, we have numerous of them, and then also making sure that there's a seat at the table for health. That when we go to DC for these meetings, that health is there. And we've been very successful with that with partnership with NIH and John Ballas. And partnerships with other sectors, NOAA, et cetera. The bad news is my little program is the only shop in town for climate and health. In the entire federal government, there's no other dedicated money, and that is a huge problem because there is a great demand for funding for this, and it's just not there. We focus our efforts on, I said, state and local capacity. We have a BRACE framework. We fund these states in 2 cities. It's not red state, blue state. It's just whoever got the best application in. And what they do is they work on shifting the coping range, identifying those things that they can do to, whether it's surveillance, communication, workforce development, to shift the coping range. And they do this using the principles of adaptive management by assessing, by implementing actions, and reviewing what they evaluate how those work. And it focuses on the risk equation where we might not have a chance to reduce the hazard probability, meaning climate change, unless we engage with co-benefit type work, but we can reduce exposure and vulnerability, and that's what a lot of these groups are working on, trying to identify the major factors in vulnerability and work towards increasing resilience through, this is our BRACE framework. This is what our grantees do is they take this 5-step framework. It starts with specific tasks at each step, the forecasting climate impact and assessing vulnerabilities, and they go through a process where they develop a climate health profile report and assess local meteorology and climatology and prospective where it's going to go. They project a disease burden based upon what they know about the epidemiology and shifting exposures. They do intervention assessments, looking at a wide range of actions that can be done, and then implement it into a plan and evaluate it. So our 18 grantees have completed this phase, 4 years, and now they're entering into an implementation phase. And our goal is to increase the number of states that are BRACE funded to 50 and keep those other states funded because the capacity is there. We do produce guidance documents. We have 4 now. This is only 3 of them, which is how to use climate models, how do you assess health vulnerability, how do you project a disease burden. Some of them with appendices, with SAS code, with R code, with how do you set up your data tables, and like really a cookbook type approach. Oh, 5?
5 more.
Oh, okay. I was rushing. I thought I was 5 minutes ago. It's not just the coffee. And what we are mindful of is because this BRACE framework is a modeling activity. It's a way of saying, how do we build the capacity so we don't have to respond every time to everything that happens, to Zika. I mean, we've been saying this is coming for how many years now? Is this a surprise? It's not. It was pretty obvious it would be here pretty this summer. And the fact that CDC is scrambling for funds, I just don't get it. There are a lot of things that we can anticipate if we push public health into a prospective or an anticipatory frame. And we have to look at it in different scales. The spatial scale with climate change, the relevant things at global scale to local. I mean, El Nino does affect the local in various parts of the world. How does it affect the local is quite important. So the temporal aspect, when we develop these interventions, we need things that will prevent people from extreme events. We need to prevent the extreme events from happening and reduce the magnitude of them. So heat islands, the heat waves, we can teach people how to stay cool and what are smart things to do. We need to develop better seasonal forecasts and put in the right people in place, a command structure to handle heat waves. We learned that in Chicago in '95, that if you don't have an incident command structure, you're going to be in trouble. But then there's multi-seasonal things you can do to reduce urban heat island effect, urban canopy, et cetera. So we want to span that continuum. And the opportunity for public health really lies in that multi-year interventions, where now we engage with urban planners in regional planning and start to affect the upstream determinants of these exposures in the first place, and with carbon reduction programs. You know, saying your program in putting bikes in is great for reducing vehicle miles traveled. Who cares about vehicle miles traveled? What about heart disease? Like Jonathan's Triple Win plan. You know, what are the real benefits for people in air quality and in active transportation? And then also administrative constraints, which we deal with a lot, and how do we get to the local when we've got to go through the state? And we can't just go straight to the local. In a lot of cases, it doesn't work that way. And then budgets always are tough because every year we fight for our budget. Last year we were supposed to be eliminated. House and Senate had us at 0, and Obama stepped in and actually got us an increase. So if you want to learn more about what adaptation really looks like in the public health sphere, we have a booklet on this. There's some stories about what the different states are doing. And we are starting a new program called the Climate Ready Tribes and Territories Initiative. The other programs are Climate Ready States and Cities, which is BRACE focused, and it requires a lot of data. It's evidence-based, empirical, a lot of statistics. We're now, because I'm an anthropologist by training, I see there was another one in the back. We're moving into adaptation planning outside of public health, formal public health departments, and we're going to be supporting 4 territories and 3 tribal, these numbers change, 4 territories and 3 tribal governments. The announcement will happen in the next few weeks. Where we're going to use new methods, community-based participatory research, some qualitative stuff, linking mixed methods with some of the more quantitative approaches with qualitative approaches, and understanding causal pathways, because they're very, very different in these communities. Not your standard, well, I have a CSO and it got too much water and now we have cryptosporidium or something. But looking at those determinants of health effects in these groups are going to be real interesting and bring in a new type of science. So that's it. Thank you.